Hello, and welcome to the Sonoma County EMS System Phase 2 Tiered Response Training. As we enter this next exciting phase of development for our EMS system, this training is designed to provide you key information that you will need in order to provide the best level of care and make good decisions about patient transport for our patients within the county. During this training, you're going to hear voices from several members of the implementation work group. My name is Art Sia, and I am the faculty coordinator at the Santa Rosa Junior College Emergency Medical Care Program located at the Public Safety Training Center.
Tim Abadera, firefighter, paramedic, City of Santa Rosa Fire Department.
Matt Windrum, Division Chief of EMS for the Sonoma County Fire District.
Yeah, hi, this is Mark Lovato. I'm the Medical Director for Coastal Valleys EMS Agency.
Hi, I'm James Salvante. I'm an EMS coordinator with Coastal Valleys EMS Agency.
So, this presentation was developed with a series of questions that we felt would be most commonly asked and allow us to move forward in describing how to engage within Phase 2. We'll be covering these questions here about why tiered response and how did we get here. And we'll work our way through operational questions, including some of the rare occurrences that might occur within the system. Let's start with the basic question. Why tiered response in the first place?
The right sizing of many systems has been providing BLS transport for the patients that need very little care or no care in the field or transport, and then ALS for the more critical patients that need the judgment of a paramedic and the treatment potentials of a paramedic. In the 2020-2021, we also saw that there was a significant paramedic shortage, not only in the nation, in California, but it was affecting Sonoma County as well.
I think it also allows EMS providers at different levels in EMS to work at their appropriate scope of practice, focusing paramedics on patients that need paramedic level care and providing EMTs that opportunity to interact with, assess, and treat patients that are well within their appropriate scope of practice.
In Phase 1, which occurred in 2023, BLS ambulances were co-dispatched with ALS ambulances that were calls that were triaged at dispatch to be low acuity. These were the so-called Alpha and Bravo level calls, and those determinants are made at the point of dispatch using emergency medical dispatch protocols. Once the paramedic on scene validated the patient's condition, if the patient was categorized as a non-urgent basic life support call, turnover would occur with the EMT ambulance and the patient was transported by the EMTs to the emergency department. Over the year, the system was monitored closely and calls were reviewed for consistency and accuracy. Based on that information, during Phase 2 development, a specific subset of Alpha and Bravo determinants would be used to assure safety in terms of the type of patient in which we would be sending BLS resources. Phase 2 will replace the co-dispatch of ALS and BLS ambulances to these Alpha and Bravo calls with a BLS ambulance. The dispatches will look like most of the time that first category, where a paramedic engine would be dispatched with an ALS ambulance and a BLS engine would be dispatched with an ALS ambulance. On certain types of Alpha Bravo calls, it will be a paramedic engine with a BLS ambulance. The way that the system is designed, we're going to be doing Phase 2 predominantly in areas that are covered by ALS engine companies. There may be occasions in which the closest BLS engine and the closest BLS ambulance will be dispatched. And these will be times when the system is in severe stress, where there's very few resources available, and ALS will follow as soon as it becomes available. Medical facility scene calls, or MEDF calls, which had always received a paramedic response, will now receive, if it's appropriate, a BLS ambulance response.
In a tiered response environment, especially for the first responder paramedics, nothing really changes. The expectation and the skill set that they need is exactly the same in phase 2 as it was in phase 1 and in phase 0 before tiered response was even part of the system. Do a good patient assessment, figure out what their chief complaint is, what their signs and symptoms are. If they're starting to look like a BLS appropriate patient, we have a tool of BLS exclusion criteria that will help you continue to determine if that patient is eligible for BLS. So in a configuration where you're responding with a BLS ambulance as a first response paramedic, if you start to figure out that this patient does have a BLS exclusion criteria, or in your judgment they need continued ALS care, just like you can do today, you can call for additional resources that you need. If it's a scenario where you're dispatched ALS and clearly a BLS patient, there's also nothing that stops our first response units from requesting a BLS unit so that that patient is transported at the appropriate level of care.
And then, you could have the BLS ambulance could arrive first on scene, and those EMTs and that crew would initiate patient care at their appropriate scope of practice and appropriate for the patient. Similarly, if they ascertain that this patient needs ALS care, they would absolutely be expected to request an ALS ambulance to do that, and then work together with the first responder paramedics when they arrive on scene to initiate whatever level of care that patient needs until that ALS or other transport unit arrives.
One existing policy needed to be revised and a new policy created in order to facilitate the tiered response implementation. Both of these policies, CVEMSA Policy 4008, Turnover of Patient Care, and the new policy 4010, EMT Transport of Emergent Patients, were revised and constructed with the aid of the implementation group so that we could try to get it right the first time. These policies are currently in public comment at the start of the tiered response implementation, but we intend to issue a special memo to cover the time period that they're in public comment until they get into a final form. CVEMSA Policy 4008, Turnover of Patient Care, has been revised to really normalize the process of BLS providers accepting care from paramedics. The existing policy that has been in effect for a while does allow for BLS turnover of patient care, but it really stressed that it was to preserve availability of ALS rather than to be the appropriate use of BLS for the right patients. We wanted to ensure that the turnover of patient care from a paramedic to an EMT was the appropriate thing for that patient at that time, and we wanted to support that with the right kind of a policy. CVEMSA Policy 4010, EMT Transport of Emergent Patients, is intended to provide EMTs the correct medical direction in case they find themselves having care of a patient that needs immediate care and transport, and there's no ALS on scene. This could be because they arrive prior to ALS and there's a delay in ALS arrival. In this case, the EMTs can look to this policy to give them direction on whether they should arrange a rendezvous with a paramedic on the way to the hospital or whether to go directly to the ED. There may be department-specific policies related to tiered response, and providers should always look to their department or their agency for any specifics regarding their practice in the field. However, the criteria in Policy 4010 and 4000 is intended to be the medical direction of the EMS agency medical director and should guide those decisions.
I think Dr. Lovato put it best when we were first talking about tiered response, and he used terms like right sizing and appropriate treatment for the patient. And so if a patient needs basic stabilizing or interventional care, so we're using the right tool. For the EMTs, this is a really positive shift in the philosophy of our system, where for the entirety of my 20 plus years working in this system, EMTs were largely there to support the paramedics.
You know, we have a system in place that's going to be ongoing for evaluation of how this system is going, so that if there are occurrences where there is an issue, an unusual occurrence, or issue either with dispatch and EMD, there will be procedures in place and regular meetings, especially in the early stages of this phase 2, to keep close monitoring for anything that might come up.
Once the work group established the different constraints and operations of Phase 2, a decision tree was developed to help visualize some of the decisions that would be made by EMS personnel on the scene or even while responding to the scene. While this decision tree seems a bit complicated, we're going to break it down piece by piece. Many of the calls that we'll run in phase 2 will be run just like we do in phase 1. The exception is that you'll either receive a BLS ambulance or ALS ambulance on dispatch. If you're arriving on scene first, you'll be doing the assessment as you normally would. You'll make a determination of whether or not this is an ALS patient or BLS patient. If our dispatch is correct, the appropriate resource should be arriving with you simultaneously or shortly thereafter. If it's an ALS patient, you're going to be sending the patient by ALS transport, just like we do today. If it turns out that the patient does not require ALS, there'll be one extra step that we'll formalize that allows us to understand whether or not a patient should be transported by ALS, even if an ALS intervention is not provided. These are called BLS exclusion criteria, which we'll cover in the next slide. If the patient does meet that criteria, they'll go by ALS ambulance. If they do not meet that, that means that they are safe to be transported by BLS. The BLS exclusion criteria was based on information that we received during phase 1 of our system, as well as input from other EMS systems in California that do tiered response. And it's exclusion criteria because if patients meet any one of these 12 areas, then we would rather have a paramedic transport this patient rather than an EMT. So things like airway emergencies, respiratory distress that's received any type of ALS intervention, unresolved hypertension for any reason, cardiac-related working primary impressions, suspected stroke, regardless of time of onset, acute change in mental status, severe acute pain where complaints of pain and physical exam are consistent, anaphylaxis, any type of OB complaint with a reported gestational age of 20 weeks or later. What that does mean is if you have a patient who may be pregnant but has a condition that is unrelated to the pregnancy, that patient may still be transported by BLS ambulance. Hypoglycemia, where the patient cannot safely take oral glucose during transport. Paramedic discretion. Any condition where it's not clear. If you have a hunch that there's something more that's going on, but you can't quite place your finger on it, let's have the paramedic do the transport. And then any patient that meets specialty care destination should be transported by a paramedic. Coastal Valleys has developed BLS handoff worksheets inside of ImageTrend. The next time you log in or during your training session, look for this particular form. The exclusion criteria we just talked about are replicated here. If you use the worksheet, patients who receive no's on all of the questions do not meet BLS exclusion criteria and therefore could be transported by the BLS ambulance. If there's a yes to any one of these, then an ALS transport unit should be used for the patient. Hopefully rarely. There will be situations where there will be a first responder paramedic on the scene with an emergent patient, and ALS transport is significantly delayed. In those situations, you may want to consider the first couple of questions. 1. Is time a major factor in definitive hospital care? Things like airway emergencies, STEMIs, strokes, or critical trauma are situations where we know that time is of the essence. The second question is the ETA of the ALS transport unit significantly delayed? So they're coming from across the county, there may not be an ALS unit available. So as you're assessing those resources, if the answer is yes to either one of these questions and BLS is available, have the BLS unit arrive and have the paramedic transport the patient to the ED with the BLS ambulance. We do think this should happen very rarely, and we want to make sure that the patient does receive the appropriate care given their condition. In the vast majority of circumstances, non-emergent ALS patients can wait for ALS transport. You may have situations in which there may be no ALS units available for some time for things like major system disasters or system overload. In those situations, if the first response engine is on scene and will be on scene for some period of time, it may make more sense to have a BLS unit transport the patient with the paramedic in the back. Again, we don't think that this will happen often, but because it is a possibility, we wanted to make sure that there was some direction on this. The second situation is when ALS is not yet on the scene of a 911 call. If they're not on the scene, we just want to confirm that ALS is in fact en route. EMTs We'll go through the assessment process, understand how long it will take for ALS to arrive on scene, and understand what the transport time is for BLS to the hospital. During this entire time, the patient should be getting ready for transport. If the patient requires BLS emergent transport, meaning that they are a critical patient, then the BLS ambulance should begin transport to the closest hospital. It's important to stress that this will be to the closest facility. Consider an ALS intercept if BLS transport time is greater than 10 minutes. We'll talk about ALS intercepts and what that means and how to go about doing that in the next slide. If it turns out that the patient does not require emergency transport, determine whether or not that the transport time to the requested hospital is less than the ALS transport unit's ETA to the scene. If it's going to be faster for ALS to arrive than it is for BLS to transport, then maintain the patient and wait for the ALS resource. In rare extreme circumstances, consider starting transport with an ALS intercept. If you are on scene and your patient is BLS and that the transport time is less than the ALS ETA, then go ahead and transport the patient to that facility. If the patient is a BLS level patient, only at that time can you cancel the ALS response. The intent is to make sure that ALS is responding up until the point where it doesn't make sense for them to do so. And we've determined that to be at the time that the BLS transport unit is departing the scene and heading toward the hospital. Setting up an ALS rendezvous is relatively straightforward. The first thing you'll do is contact the control channel as soon as you have time to do so. We would like it to be on scene, so basically as early as possible. You've already made the decision that this is an emergent patient that requires ALS care, and so you'll be starting to extricate that patient out to your ambulance. Again, once the patient is loaded and you know the responding ALS resource, you're going to be able to communicate with them on that control channel. You may be asked to provide patient condition EM updates and then maybe specific information about where to do the rendezvous. At the rendezvous point, the paramedic will join the patient and the EMT who's attending to the patient in the BLS ambulance. The intent of the rendezvous is to only stay on scene for just a couple of minutes at the most. And that's basically to help situate the paramedic so it's safe for everybody in the back of the ambulance to continue transport. There may be situations where it may take a little bit longer. So for example, it might be a cardiac arrest or something that requires immediate intervention, that requires a stable platform for that intervention to happen. Those decisions are made among the medical crew, so that may vary from case to case. Once everyone is situated, the ambulance resumes its transport to the facility that it was originally going to. To reemphasize some points, if you have a non-emergent patient and that the receiving hospital is closer than the ALS responding resource, then it makes sense for you to take the patient to the emergency department. You'll have to factor in the time it takes to package and extricate the patient, so it isn't just your wheels up time, but you're going to want to take the whole thing into consideration. It's really important to not cancel the paramedic resource until your wheels are turning. Once you are en route at that particular point, it will still make sense for you to transport to the emergency department, especially if ALS will take even longer to get to you and that an intercept is not possible. Non-emergent patients should be transported to their requested hospitals. What if there is a conflict between providers on the scene in terms of how we are transporting the patient? Like medical professionals, we would expect that any conflict or disagreement will be discussed. It should be discussed out of earshot of the patient and the family. Work your way through the BLS exclusion criteria to make sure that that is satisfied, and the decision should be jointly made by the paramedic and the EMT that's involved with the transport.
With any difference of opinion on patient transport, I think it's clear that this will happen, and the different crews can have a collegial discussion away from the patient. And I think the default will be to, for instance, if a BLS crew feels uncomfortable transporting the patient, then that patient should be transported by the ALS crew, and it can be discussed afterwards in a review. If there is a discussion between the ALS and BLS crew away from the patient, and there can be a change in the BLS crew that it is safe, then that's obviously appropriate. But I think the default will always be for, first of all, patient safety, and if a BLS crew feels uncomfortable in that moment to transport the patient, it should default to an ALS transport.
We really don't anticipate this to happen, but because there is a remote possibility, we're going to talk about the situation where a BLS engine and a BLS ambulance are dispatched only. In those situations, contact REDCOM right away to request an ALS response. It's very likely that REDCOM will be sending someone and they will be telling you how long it will take to have that ALS response arrive. But you'll move forward with the patient at BLS and follow the guidelines that we talked about earlier if the patient needs emergent BLS transport.
Throughout the conversations about this expansion of tiered response or this phase 2 of tiered response, that this is an environment that we recognize is a change, but is set up to be safe for our patients and safe for our providers. In those situations where something doesn't work out quite right, or there is some part of this system that doesn't go as planned, that if there are corrections that need to be made, we view those through the lens of education and exposure for providers. So looking at where the system needs to do better, where we need to provide more training. It is not viewed in any way as something that's going to be disciplinary towards an individual provider because of system issues or challenges that come about there.
I think it's important for all the providers to understand that this isn't something that someone or some group just made up. Everything that we're doing here is we're following in the footsteps of other systems that have done it. The EMD call interrogation process that we have has its own level of medical direction, its own level of study, and it's an internationally used and accredited system. This is another opportunity for EMTs and paramedics to fully use their skill sets to bring the right treatment to patients.
I can say I'm very excited about initiating phase 2 of our tiered response process, because I think it really is going to be the best for our current system, both in terms of right-sizing our system and providing better care for the patient and more cost-effective care. This will be a new process for all of us in the system, from the BLS to the ALS providers to the hospitals where our patients are going. And it's going to be a learning process that will be reviewed on a continuous basis. And we understand that there will be learning issues for all of us. This will be looked at as an educational process for us all to learn to make it a better system. And we'll have to have patience with ourselves and each other. And this will be the focus of our review, which is educational, non-punitive, so we can make this system work as well as I expect it to.